Good evening from the United Kingdom. My name is Satish Kutty. I am the chair of the Education Committee of the British Hip Society. I welcome you to this webinar with the Asia Pacific Hip Society. I'd like to pass on to Anil Gambhir, the president of the Hip Society, to say a few words.
Thank you, Satish. Welcome to this ongoing Global Reach series, which we now enters its second year. It's a real privilege and honour to have the Asia Pacific Hip Society with us today, where we're going to be talking about a number of subjects, including complications around hip arthroplasty. So without further ado, if I hand back to Satish, who will introduce the faculty.
Thank you, Anil. Louis Chan is the current president of the Asia Hip Society. So I pass on to him to introduce the faculty from the Asia Pacific Hip Society. Louis.
So thank you. So welcome all the participants. I'm Louis Chan, the president of the Asia Pacific Hip Society. So today is our great honor to join the Global Reach webinar organized by the British Hip Society. So today we have a good panel of speakers from the Asia Pacific Society, including Abhay from India. He's the president-elect of the Asia Pacific Hip Society. And then we have Professor Shahid Noor from Pakistan. He's the immediate past president of the Asia Pacific Hip Societies. So I'm sure we will have a good case presentations in this webinar. So with that, I pass it back to Satish to introduce the BHS speakers.
Thank you, Louis. So our first speaker from the British Hip Society is Nikhil Shah. He's a consultant orthopedic surgeon at Wrightington. Then following that will be Tim Petheram, who is a consultant orthopedic surgeon at Northumbria. And the following that will be Samantha Tross, who's currently a orthopedic consultant at London Northwest University Healthcare NSS Trust. So the first case is going to be on the complication that Louis is going to present. And there'll be a discussion between Louis and Nikhil. Louis, off you go.
So thank you. So I'm going to present the first case, complications related to dislocation in total hip. So let's have a brief history. She's a 64-year-old lady, history of rheumatoid arthritis on DMARD, and then complaint of right hip pain. She had a right total hip replacement done in a private hospital in Hong Kong and by conventional technique through posterior approach. This is the post-op X-ray. But early post-op, within 6 months, she experienced 3 times dislocations. All the cost reductions was done in A&E department of our hospital. And so we do not know the stable range after the relocations. And then eventually she was referred to our hospital for further management. So this is a post-cost reduction X-ray. This is a congruent reductions, all the components stable. And then this is the dislocation X-ray, post-coast reduction X-ray. These patients suffer from recurrent total hip dislocation early post-op. So can I right now invite Nikhil to have some suggestions?
Can we have some more details about the history? You mentioned usual daily activities. Can you specify a little bit? Was she bending forwards or twisting?
Yeah, she did not describe in very details, but just on standing, walking, turning, just very trivial activities, not extreme positions. She already experienced dislocations.
And other dislocations?
The by A&E officer came to be very easy, just under sedations, easily reduced, but they did not test the stable range after the cost reductions.
Okay. And do we have any other details about the type of implants used, the geometry, any technical details, if the hip was stable during surgery, whether they tested for impingement or range of movement or anything like that?
Because the surgery was done by a private surgeon, we cannot get a lot of details from that. But basically, it is all cementless total hip, 36 head. And from the impressions, I think this is from a specific company, Stryker. So that is all we get. We try to contact the private surgeon, but we cannot get any further details.
Okay, that's fine. So my approach to this would be like yours, to take a detailed history to try and get some details about the old operation note if possible. I like to get some lateral oblique x-rays just to see whether there is any obvious problem with component positioning. And then for all dislocations, routinely, I would like to rule out infection because sepsis can be a cause of dislocations. And then I generally go for a CT scan to look for the component positioning and version, as well as the stem and the socket position. Based on this X-ray, compared to the other side, I think the offset looks quite reasonable. The angles of the cup don't look completely out of what you would expect for a normal range of hip replacements. So I don't think there's any obvious thing staring at you.
Yeah, I agree. I think one of the important cause of early post-op dislocation is component positions. With regard to leg length here, it shows the right lower limb is shortened a little bit. So in general, so these are the factors when I encounter a case of post-op dislocations. We need to consider patient factor, disease factor, and the surgical factors. As highlighted by you, I think implant position is one of the key things we need to assess. So any recommendations to assess the component orientations apart from X-ray? So we basically use this CT. But I know that there are different measurements of cup positions, stand versions. So what methods you usually use to assess implant positioning in CT?
So I like to look at the version of the acetabulum, the native acetabulum, as well as the implanted one. On the axial scans, on the coronals and on the sagittals, you can look for the component position in the two other planes. I also like to look at the soft tissue sequences of the CT scans, because many times as your dislocations progress and they happen again and again, you do get soft tissue scarring and impingement from the hematoma that forms. And often that leads to easier and easier dislocations. Then one more clue that you can sometimes get, depending on the type of the bearing used, is whether there has been any obvious macroscopic damage to the bearing. And then on the coronals, we can look for whether the cup is open or whether it's symmetrical.
Yeah, I think that's very important. Apart from component position, we need to look at soft tissue. So we did a CT scan as by the technique mentioned by Japanese surgeons. The stand versions 22 degree, cup versions 23 degree, cup inclinations 40 degree. So basically, I think this is still within the laminar safe zones. So what is your comment about laminar safe zones? Do you think this is really a safe zone?
Well, to be honest, the work on safe zone that was done by Leeuwenhoek was based on methodology that can now be considered to be under question. And subsequent work from the Mayo Clinic showed quite well that the vast majority of hip dislocators, their component positioning actually falls within the safe zone. And in fact, the component positionings that are outside the so-called safe zone don't always dislocate. So dislocation is quite multifactorial, and component positioning alone doesn't influence instability. I think a more important cause will be whether your hip is balanced in terms of your offset and soft tissue tension, not just in the coronal plane, but also in the sagittal plane, and whether there is any impingement in a range of rotation.
Yeah, I agree. I think this is very important on this. Laminar safe zone is probably traditional, but right now we know there's some limitations with regard to laminar safe zone. So this is what we get from the PO imaging. So these patients suffer from recurrent dislocations. So we have the CT scan, seems the component positions not too bad. So apart from some leg length discrepancy, so any further suggestions for workup, or you suggest revisions?
So I do like to rule out infection. So I'd like to know what the bloods are. And
so
at least in my practice, I would... Yeah, sorry, go on.
Infection rule out in this case, so
ruled out just by bloods or by an aspiration as well?
Including aspirations, it doesn't satisfy any MSIS criteria.
Okay.
And then,
so if the patient is significantly troubled by this hip instability, has lost her confidence, and her mobility is being compromised, and she has good ambulatory prognosis, in other words, if that hip replacement were not dislocating, she would become an active or reasonably active person, then I think you're heading for a revision operation.
Thank you. I think these patients definitely need revision surgery. So we actually did some other workup as shown here. We did a EOS X-ray as shown here. This is a standing lower limb scanograms. It shows the perfect position in standing positions. So anything that worry you or that have potential implications to revision surgery?
So I think she's got some scoliosis of the spine. And I don't know whether you have sitting and standing x-rays of the spino-pelvic alignment in the sagittal plane, because sometimes that gives you a better idea of the functional arc of safe movement or the functional range of movement where she doesn't impinge. Because we know that the static impression the surgeon forms of component positioning during surgery can be quite dramatically different when the patient actually stands and starts walking, based on how much flexibility you have at the junction between the spine and the pelvis.
Yeah,
But
I agree.
Whilst this is theoretically quite useful to discuss, I don't think there is enough data to give us a recommendation for treatment.
So I think you mentioned one of the very important points. We need to assess the functional positions, especially functional cup positions. As shown here, the X-ray show actually the pelvis more or less like an outlet view. That signifies the pelvis actually retroward or hyperextend a little bit. So actually, when we look at the hip, we need to look at the spine. This is supine X-ray and standing X-ray. One show the pelvic rotation change upon changing the position from supine and standing. So standing X-rays look like an outlet view. So what is the reason for that? Actually, we take a long film, including the spine, as shown here. Actually, it shows a kyphotic deformity over the thoracolumbar junctions, as shown here. So, and then as shown here, actually, to maintain the surgical balance of the spine, the patients need to hyperextend the pelvis or retroward pelvis, and actually need to flex the knee a little bit to maintain the surgical balance. So as a result, when the pelvis retroward, it changes the functional cup positions. So this, once again, supine AP X-ray of the pelvis. This is standing AP X-ray. It shows an outlet view of the pelvis because of pelvic tilt in order to maintain the surgical balance. So, and we know that when the pelvic tilt, it changes the cup anteversions and inclinations. So as in our case, when the pelvis retroward, it increases the functional cup positions in terms of increasing the anteversions and inclinations. And we know that whenever there's a pelvic tilt change of 10 degrees, we change the cup position as shown by figures here. So this is our patients once again. Pelvic retroward. It changed the functional cup position and then repeatedly posterior impingement and then anterior dislocations. So in summary, as shown here, these patients with recurrent dislocation have a surgical imbalance of spine and then wider limb shorter. So any recommendations for that? You prefer revision total hip or another way, because the spine is probably the primary pathology? Would you consider to refer to spine surgeon for the corrective surgery for the spine?
She's a 64-year-old rheumatoid lady. So I think, at least in our setup, unless her spine is symptomatic, it is very unlikely that she will be offered spinal surgery. And even if the spine is symptomatic, we know that spine surgery for correction of degenerative symptomatic malalignment is not always spectacularly successful. So there's no harm in obtaining an opinion, but I suspect that the treatment actually lies within the hip rather than within the spine.
Yeah, I think you mentioned one of the good points. The patient's symptoms is one of the important considerations. And actually, this is one of the papers published by my department head. So actually, these patients have a surgical spine imbalance as measured by surgical vertical axis. This is the vertical distance between the SC7 pump line towards the S1, and then it increases more than 5 cm. So it means a surgical imbalance. So in this case, a spine surgeon do the correlative spine osteotomy because of the back pain of this patient and surgical imbalance. But in this case, we have different options offered to patients: spine surgery, revision total hip. So we have a shared decision-making, detailed discussion with patients. We finally offer right revision total hip. There are different options as shown here: full revisions, isolated cup revisions, and then different bearing surface. And let's see what we did. Before the revisions, we tried to test the range, stable range of patients. It showed that the right hip definitely anterior sublux upon extension and external rotation as shown here. So finally, this is what we get. This is one of the pre-op and post-op. Pre-op, we are able to get the implant details. This is a Trident cup, 36 ceramic head, and secure fit stand. So we do an isolated cup revision as shown here. We take out the old cup and put in a new cup, 52 Trident 2 cup. We decrease the anti-variations of the cup, and then in taking the reference of the transverse acetabular ligament, because when the patient stand up, it will increase the functional anti-versions of the cup. And then we change it to modular dual mobilities, as the bigger hip ball in modular dual mobility increase the stable hip range. So this is a post-op scanogram. You can see the standing and lateral view of the spine and the pelvis. So this is pre-op and post-op. You can see that we deliberately decrease the anti-versions of the cup. So this is pre-op and post-op X-ray. You can see upon standing, despite the pelvis retroverted, so after revisions, the cup still remain in a safe functional positions. And then after operations, patients don't have any dislocations. So this is the case I present. So I just make a simple conclusion first. This is the factors we need to consider whenever a patient's encounter, when we have a case of dislocations: patient factor, disease factor, and surgical factors. In this case, we saw implant malposition in terms of the cup position, and then the length discrepancy we correct in this surgery. So I think one of the important message in the pre-op planning in doing total hip, we don't just need pelvic AP X-ray alone. We need to understand the spinal pelvic kinematics. As a result, as shown here in this video, the spine and pelvis actually work together. So in standing and sitting, actually the pelvic position change. If there's a very stiff spine, the pelvis cannot retrovert on sitting. It will cause anterior impingement, posterior dislocations. So this is a bring-home message as shown here. So certain imbalance of the spine we need to take into considerations in planning a total hip, and then accelerating cup implantations based on neuralization may not yield a definite safe result. And then in a functional assessment of cup position, we need a standing AP pelvis and 2 lateral radiograph as discussed, sitting and standing. And one of the calculations of the hip spine kinematics is HSS hip spine calculations. Because of time, I cannot go into details. So with that, thank you for your attention. So any comments or questions with regard to this case?
No, well managed. Nicely managed, Dr. Chan. Very interesting case. Thank you for sharing your experience.
Yeah, thank you. Thank you for your input. I think right now we need to look at the functional cup positions as discussed and mentioned by you. And then we need a standing AP pelvis X-ray and 2 lateral radiographs sitting and standing. Thank you for your input. So if no further questions, I pass it to our second case moderators and then to discuss on the same case.
Okay, Lewis, you're moderating the second one. So off to Syed.
Hello, so Syed, Syed will present the case of infections, and then we have a team to comment on the case. So please, Professor Syed.
Thank you very much, Lewis, and thank you very much. I'm extremely grateful for this opportunity, British Hip Society and Asia Pacific Hip Society, and complication in total hip arthroplasty. My presentation is going to be on infection. It has 2 parts. So this is the case of a 64-year-old male patient who presented with a traumatic fracture of his right femur. His mobility prior to current fall was that he was using a walking aid and shoe raise on the right side. He also was on a regular analgesic for right groin pain. Past history: 10 years ago, he sustained fracture of his right femur and underwent open reduction and bone grafting. Unfortunately, 1 year later to his surgery, he presented to the operating surgeon with a discharging sinus. The implant was removed, previous record of organism grown are not available. He had been infection-free for last 9 years. These are the X-rays, AP, and a lateral view of the femur. And here is the question for you, Tim. How would you manage this patient who is medically fit? Would you manage his femur fracture in isolation? Or you would manage femur fracture and right hip advanced arthritis in one go? His hemoglobin is 13.4, his white cell count is 8.4, and his CRP is 1.4. Over to you, Tim.
Thank you. Excellent case. And, that nails the question, doesn't it? It's what are we addressing here? Are we just addressing the fracture, or can we actually maybe help this gentleman beyond just addressing his fracture? He was clearly struggling quite a bit before he refractured his femur by the sounds of it, wasn't he? Using walking aids and so on. Is that correct?
And regular painkillers and analgesia.
Yeah, I bet. It's a bad hip above there, isn't there? So also, what of course adds interest to the case is this previous history of infection, which makes us all twitch a little bit, I think. Appreciating the inflammatory markers there are totally normal, which maybe offers some degree of reassurance. I think we can all be slightly worried about the previous history of infection. And do we have information on what implants were used in the first place and then removed? Did you manage to get
the previous records are not available. It appears that looking at the X-ray, it appears to be some angle plate with screws and obviously interfragmentary screw I can see on the neck. But previous record, unfortunately, of the implant and of the organism, unfortunately, are not available with the patient.
Yeah, it always makes life more difficult, doesn't it? If this patient has been through your own hospital, then there's a lot more information available. But in our country, even as well, when patients come from different hospitals, it's often much more difficult to obtain the daily like. So I think it's a difficult situation, and I think it's very appealing to want to deal with both problems in one operation. As always, I'm sure our populations engaging the patient, their family, and having a discussion about the options is really important. And I think that would be very important in this case, to get a feel for how much he was troubled by his hip, offer him the two options, either dealing with the fracture or both the fracture and the hip arthritis. And I suspect he would be delighted to hear that his hip could maybe be better, as well as dealing with his acute injury with the fracture. So I think that would be my initial thoughts. With regards just dealing with the fracture, of course, the problem that you face there is you're in quite a difficult biomechanical situation. That hip must be pretty stiff, I think. So any attempt at just dealing with the fracture is tricky. The advantage of just dealing with the fracture, of course, is that then you could biopsy the area and just try and reassure yourself there's no residual infection from that previous problem. I mean, it was a long time ago, but that's always going to be a bit of a worry. So I think I'm heading for doing both in one go, but very much, as I say, engaging with him and his family. Thank you.
I totally agree with you, Tim, that it was a long discussion with the patient and with the family. And we discussed possible complication and failure rate. So what we did, we discussed with the family, and eventually, obviously, the patient was excited that his hip problem could be resolved, his leg length difference could be resolved. So we opted for both pathologies, dealing with both pathologies simultaneously. Obviously, we said that if there was a gross infection and on-site, we have some report that there are infection, we will have a second policy. So the approach was a lateral hardenings approach. For proximal femur, we did a ETO. We took multiple cultures. We removed the screw. Femur reconstruction was done with a tapered fluted modular stem and bone grafting. The ETO was closed with wire. Acetabular reconstruction was done with bone grafting and a dual mobility cup. All intraoperative cultures sample did not grow any organism. Patient was kept non-weight bearing for 4 weeks, and after that he was mobilized full weight bearing. This is 18 months post-op, X-rays of his hip and femur. Patient now is absolutely pain-free. He's walking without walking aid, and he's back to his normal activity. Very happy with the result of the surgery. And he did not require walking aid, shoe raise, and analgesia. At 2 years follow-up, he came with pain, swelling, fever. We did investigation. ESR was 48. His CRP was 52. We did aspiration, which grew MSSA. So, Tim, it's a challenging problem in the beginning. How would you manage this patient now?
I think this is a challenging case all the way through, isn't it? From his very first visit to hospital. So I'd just like to make a couple of comments. So that's excellent. Clearly you've sampled now, and you've got that information in your laboratory. How many samples do you tend to take? Is it a kind of fairly fixed number, or?
Yeah. So up till now, it is just on an OPD basis that we have done aspiration. So we have a laboratory figures of inflammatory marker which are high, and we have a culture report. So we now have to make a decision at whether we go for a DARE and retain the implant, or we have a question of removing the implant, and obviously you will take multiple cultures at that time.
Absolutely. And the cultures that you took when you treated his fracture in the first place. So we always tend to follow, the Oxford data that suggested always 5 tissue, 1 fluid. So we pretty much stick to that for everything.
Yes.
That's the regime you follow, I'm sure.
So in the first procedure with the removal of implant, 5 samples were negative for culture. And 18-month follow-up, he was absolutely fine.
Yeah, excellent. It's just worth as well reminding the audience that's always, there's consensus on that with Parvizi's international consensus work to always do the 5 samples is helpful. So now we're in a very difficult situation. So with that previous history of infection, be this related to that or not, this gentleman's obviously somewhat prone to having infections, one could suggest. And we were just having the first UK Bone and Joint Infection Society meeting last week, where we were hearing about work that suggests that any infection within the first 3 years actually does relate to the surgery. We'd all like to think it's something different and not relating to our surgery, of course. But life is not so simple, particularly with large cases like this. So for me, a DARE is not a sufficient operation, I don't think, to deal with this situation. He's had problems with infection before. He's got a big implant in there now. We've dealt with the fracture. There's cables. There's clearly the work you did looks excellent mechanically, but there's quite a lot of implants in there, and there's a lot of areas where there could be infection and biofilm that you wouldn't get to with a DARE. So I think this has to be treated with removal of everything. Again, given the overall complex situation, for me, it's a 2-stage operation for this, I think. So it's difficult, but it's a bit of a heart sink as well. After all that great work, but 2-stage, yeah.
So this was my question to be asked. So I agree with you. I'm also a 2-stage surgeon. So again, a difficult discussion with the family, a lot of disappointment, and some finger pointing, and so. We said, look, simple debridement and simple DARE is not going to resolve the problem. He is going to continue to have a recurring problem. So we totally agree with you, Tim, that remove all implant, all the screws, all cables, all wire, and it was well fixed. There was a gross infection. We took multiple samples, and as you said, that 5 samples we took, and 3 grew MSSA. So he was discussed with the ID person, appropriate IV antibiotic were given, and you can see that we have made a cement spacer with antibiotic and IV antibiotic. 6 weeks down the line, his wound had healed nicely. His inflammatory markers were coming down to not absolutely normal, but significantly down. So second is stage reconstruction. On the acetabular side, we use a revision dual mobility cuff, which has a hook underneath the transverse acetabular ligament, two superior wings, is HA coated and dual mobility, and the proximal femur bone loss was reconstructed with cemented proximal femur replacement. Multiple cultures at this second procedure, 5 samples were all negative for organism. These are the X-rays, AP, and a lateral view. And this is 2 years follow-up since his second surgery. Patient is back to routine activity. Clinically, he has no sign of infection and very excited back to his work. So the lesson learned, PGI remains a challenge globally. Prevention of PGI is the best strategy. Obviously, there are host factor, there are environmental factor, and there are surgical factor. And total hip arthroplasty in patients with failed hip fracture fixation, especially with retained implant, are at high risk of PGI. If there are any questions from faculty and participant, Tim will be happy to answer, or I'll be happy to answer.
Mm-hmm. I mean, there's a great case. I really like your two-stage operation has been excellent. It's tricky in those ones, isn't it? You have to manufacture some sort of extensive spacer like that, and it looks like you did a good job. You got him through the time period. Okay. Occasionally, I will use a very small size, maybe a long but a cemented implant wrapped in cement as that temporary spacer and a very loosely cemented socket. But it's always a challenge, and sometimes you just have to make something yourself. Which that looked excellent. I think I'd have one question about, so we're really, particularly in this last couple of years, we've got a huge focus in this country now as working in teams, multidisciplinary teams with our microbiology and infectious diseases colleagues. And it's, I think it's a great thing. And I think we all did it to a point in the past, but it becomes more and more of a focus. I wondered in your countries how that sort of push is occurring, and then if you're able to work in big teams like that now. With lots of regular meetings and so on.
Tim, I've been involved with Jay Parvezi. I was there representing Pakistan in 2018 at Philadelphia. I'm also invited in next year at Istanbul. So we follow, and we are trying to develop a team. We have infectious disease personnel, but these infectious disease personnel have to be trained for musculoskeletal infection. So a routine ID person is not a good candidate. So you need to involve. So I'm actually asking my ID person to do fellowship with me so that she is trained in musculoskeletal infection. So we deal with these infection cases aggressively, and we would like to make like a tumor board. So each case needs to be discussed with the ID person and surgeon, and sometime we require plastic surgeon as well.
Absolutely, and that's exactly it, isn't it? And this is definitely the way forward. The expertise has to sit in both camps. It's no good doing lovely surgery if you don't have the right implants and the right post-operative antibiotics and care. And this is clearly the way forward. That's excellent to hear, isn't it? And then I think my only other comment or question, again, having had those previous fractures, I mean, the bone looked in bad condition. I assume you had to resect some of the bone, which is why we've ended with the proximal femur replacement. And it's just, again, to reiterate that all infected material, any dead bone, must be debrided, mustn't it? Which you've clearly done an excellent job of there.
Yeah. One of the complications of revision surgery is dislocation, because the abductor mechanism are severely injured and they're prone to dislocation. And if you look at any national registry, so routinely I use dual mobility for my revision hip cases to at least reduce the rate of one complication.
Yeah, I think this is absolutely correct. At least dual mobility or even constrained devices sometimes are needed, but ignoring that at your peril, this man needs no more complications or operations, does he?
Yeah.
One of the audience has asked, audience or maybe faculty, I beg your pardon, has asked a question about he's asked Usman Khalid how to prevent biofilm forming with the spacer. I guess maybe he's asking what you put in the spacer, and or do you augment it with any other antibiotic carriers in the wound?
No, I've not put any antibiotic carrier. We had the organism, so we put vancomycin and a specific antibiotic according to culture, right dose combination. So I'm not too concerned about biofilm in my spacer, but yes, in doing the second stage, I use rifampicin as a preventive strategy in combination.
Yeah, exactly. And again, it's this working together, isn't it, with our colleagues to get the right antibiotics.
Yeah.
And spacers with really high, extremely high doses of antibiotics get you such a high local concentration of antibiotics that they're extremely effective, aren't they? That's the way to do it. Get the right antibiotics in the cement, I'm sure. Yes, someone was asking about rifampicin. You've mentioned it. That's perfect. So, how to decide the length of the stem in PFR cases like this? We've got another question.
I think that's it's nothing to do with the PGI. So all proximal femur replacement would require certain length, and I use about 80 to 90 millimeter stem would be fine. I would not go beyond that.
Absolutely, I would agree, and the companies will always give you advice on the mechanics of their implant. There was a question about do we need to use vancomycin given the MSSA, but I mean that would be our common practice too. I mean you need an antibiotic that's effective in the cement, don't you, and not going to be harmed by the cement. So vancomycin elutes really well from bone cement, and I'm sure that was what was in your thoughts.
Yeah, and these patients are prone to multiple infection according to ICM. In PGI, you must continue with some form of antibiotic for 12 weeks, according to ICM, because it's not just preventing the infection, because this host is prone to infection, and to prevent secondary infection in your mega implant, it is recommended to use antibiotic for 12 weeks.
Thank you. I think we have very good discussions about the case. I think key things, a multidisciplinary team, and then radical debridement, difficult bone loss procedure. We probably stay with a 2-stage, and then we need to have collaborations with microbiologists for the antibiotic treatment. So thank you for the highlights of this of the case. So because of time, we go to the third case. The third case is going to be sent by Abhay. So it's on the Periprosthetic case, and it's a great honor to have Samantha to comment on the case. So please, Abhay.
Hi, thank you, Lewis. Am I audible?
Yes.
Yes.
So ours is a very interesting case of an octogenarian who had an issue following a surgery. So this was an 80-year-old, had a symptomatic bilateral osteoarthritis of the hip. The right side more symptomatic to the left, but bilaterally symptomatic, affecting activity of daily living. And this is what she looks like. So Samantha, what are your thoughts on this?
Thank you very much, Abhay. So we can see that the patient has bilateral hip arthritis, as you mentioned, more significant on the right side. We can see complete loss of joint space there, sclerosis and osteophytes, particularly on the inferior aspect of the acetabulum. Something to pay attention to because that may impact the dislocation, and we don't want to cause a fracture there. I can see that the hip appears to be internally rotated there. The obturator foramen is less visible, which is unusual. Maybe the radiographer had turned the leg internally. I can see fractures of the right superior and inferior pubic rami, which would suggest perhaps underlying osteoporosis. And then, of course, casting my eye to the spine, I can see some degenerative changes there, and that may impact component positioning. Now, looking at the femoral shape, I would say this is a door B shape, which means that a cemented or uncemented prosthesis could be used. But in my practice, someone of this age, I would go for cemented implant just because there's an increased risk of dislocation in patients with osteoporosis.
Great point, Samantha. So essentially, basically, elderly osteopenic lady has had some injury to the pelvis earlier, and with symptomatic arthritis on both sides, with some element of degeneration and affecting her daily activity. So would you at any point in time consider her staging? Would you do them separately or simultaneously, or would you stage them, and how would you stage them when you decided to do it?
I haven't had any history on the patient's medical status, but someone of 80 years old, it's quite a significant undertaking. So even though she may be fit and well, but I'd like to find out a bit more of her history. In elderly patients, I tend to do them separately.
She was a significant asthmatic, and she was a hypertensive, and some element of fluorosis, probably from the belt she came, otherwise largely okay. Just the symptomatic arthritis.
I would tend to go for stage procedures. I wouldn't want to do them both at the same time.
Right. So even if she's symptomatic, and do you have a guide point as to how far between the two surgeries you would give them?
Well, I like them to recover sufficiently from the first. So it's usually a minimum of 4 to 6 weeks when I've done it, but I've done it in younger patients. I can't say I've ever done 2 bilateral hip replacements in someone of this age, but it's usually once they've recovered sufficiently.
Great point. So this is what we decided as well. It's just that we wanted to take her for the contralateral side slightly earlier because her hip was symptomatic on the left side, and she was from far away, so she wanted to, get well and go back. So this is the hip that we did for her. Any thoughts or comments?
The implant looks well fixed. Is that a chorial stem you've got there?
That's a Griptian chorial stem. So
yes. Well, I mean, the positioning looks satisfactory. You tend to want to fill the canal, but not to get, you don't want to be touching the cortices. It perhaps could be slightly, a larger component could perhaps have gone in there, but I understand in an 80-year-old, you don't want to risk a fracture. But apart from that, I think that the cup alignment, etc., appears satisfactory. I can't see anything I'd like to say, anything adverse there. Everything looks satisfactory.
So very important points you made, Samantha. So hybrids are the way to go. Staged is the way to go. The second stage is basically dependent on the morbidities. And your bearing of choice would be?
Metal on poly. To someone of her age, yes.
Great. Okay, so metal on poly, we use ceramic on highly cross-linked poly. So this is, we went back a couple of days, about 2 weeks down the line, and we did the contralateral side. And during her procedure on the contralateral side, there was a slight vertical split on the lesser trochanter. So we wired it prophylactically just to be sure that we didn't open up and cause problems to her left hip. So any comments on the X-rays?
Again, I mean, the prosthesis seems well fixed. If there's a fracture intraoperatively, I make sure I trace it all the way down and make sure I get to the base of it. I probably would have gone with 2 wires, one above the lesser trochanter and one below. But other than that, I think the implant looks well situated within the femur, and I'm happy with the cup position.
Yeah, so we had a very solid stem. We had a comfortably placed cup. We had a good combined anteversion on both sides, and we were ourselves pretty happy with what we did. So the patient was started on full weight bearing walking, but just in a couple of days, she complained of pain on the proximal thigh and hip region on the left side. And she also complained of tenderness on the right hip. So we were a little averse, and we did X-rays to see if there was a problem. And this is what we thought we had. Any thoughts on that? So this was questionable. And actually, we took her into the OR, and we took Shyam images as well, because we were ourselves not very sure what was there. And I don't have the Shyam images because they were not stored, but I can tell you for sure that there was a fracture in the region with the wedge valve encircled. So what would you do at this point in time? How would you classify it? Something in the region of the spine, there was a distinct fracture, and what would your treatment plan be? What are your thoughts?
Well, a fracture around the stem is certainly going to be in the Vancouver B classification. And then you have to decide whether the stem is well fixed or not. I think the fact that this has happened so early after surgery, there's no time for any ingrowth into the prosthesis. So therefore, I would deem this prosthesis to be loose. And therefore, that would put it into a B2 category. And if it is a B2 category, then the ideal management would be to bypass the fracture with a longer stem and then consider whether you augment that with just wires or whether you add cortical strut grafts or a plate. If someone wasn't particularly medically well, then one could consider just fixing the fracture, bearing in mind it may give a lesser outcome, but in elderly patients who are unwell, that is a consideration. So that's an option. Yeah.
Very, very important point, Samantha. Great points, actually. In a 2 weeks old periprosthetic fracture, the basic problem is that the stem is not ingrown. So obviously the stem in the metaphyseal region, and that to a tapered stem, is loose. So the basic idea is if the patient is well, as you said, it has to be revised. And these are the basic classifications that we have. And would you just like to talk us through what are your thoughts on how you would decide whether the stem is stable or loose?
Yes, it can be difficult. And I think when you look at the literature, some will agree that people who have deemed fractures to be a B1 fracture actually turn out to be B2. Now, some of the things you can do, if it's a patient who is presented to you down the line, then you can look at serial radiographs to see whether there's any signs of loosening of the component. If the patient was symptomatic, having thigh pain or difficulty weight bearing, etc., that may suggest there's some element of loosening. But then when you look at the prosthesis itself, you're going to look for any comminution around the stem. If there's comminution of the proximal of the metaphyseal region, then the stem is definitely going to be loose. Any lysis around the stem, any deficiency in the cement mantle, these are things that you would look for. And sometimes it can be difficult, and you have to wait until you go into surgery and then test the component intraoperatively to see whether it's loose or not.
Absolutely.
In terms of the stem types, the composite beam types of stem, where that depends on the bonding of the cement to the prosthesis. Once there's a fracture, those stems generally tend to be loose. The tapered stem, if the cement mantle is intact, they can sometimes be stable, but if there's significant subsidence, then you have to think about that as being unstable. And if you've got a long, well-fixed, fully coated stem, and it appears fixed, that you may be able to get away with just doing an ORF.
So brilliant points there. So essentially, a clinical history is extremely important. Patient complaining of pain on weight bearing. Radiography is very, very important. The type of stem has a lot to do with what one is going to decide, and the final decision has to be intraoperative. So even if you suspect there is a B1, one has to be prepared to revise. So this is what we did. We did a Wagner, and the patient was fine after that. And we started, we've taken a call on whether to fix or revise, and we are very clear that a fracture around the mantle within the first 2 weeks, obviously the stem is not ingrown, and the stem is loose, so we have to revise. And this is the fracture is very clearly visible here. So we did a Wagner, and we put the patient on weight bearing. And this is some very good literature saying that the results of revision in the periprosthetic fractures of B type are much better because the mortality, 1-year mortality, is about 12% as compared to ORF, which is about 33%. And the other literature which I'm quoting is that, as Samantha very clearly discussed, that it's very difficult to differentiate between a B1 and a B2. And about 47% of stems or fractures considered B1 and treated as a B1 actually turn out to be B2. And this is diagnosed only at the time of the revision. So one has to be wary, and that is why we chose to do a Wagner for her. The lady went back walking, and a couple of days later, this is what we saw. Again, Samantha, what are your thoughts? Are we dealing with a loose stem, or is it a...
I would say exactly the same, Abhay. In fact, on this side, the fractures is even more obvious. It was very unclear on the right side, so definitely a loose stem, and so we'd have to go for the same thing, bypassing it with a long stem.
So the same logic as we discussed earlier. So probably what we've had was a day 0 or a day 1 bilateral periprosthetic fracture, which was undisplaced, and that's why we missed. And when the patient got on walking for a couple of days, with the osteopenia, with the other issues, probably these splits caused a fracture. So yes, the stem is loose. Again, the same argument, and this is what we did. We revised her on the contralateral side. And this is her 18 months post-op, a very happy lady. And I've not covered her face because she gave us permission to thank us publicly. And she's a very happy grandmom. Her granddaughter is a registrar in in ENT with the hospital. So obviously she was put on medical supportive therapy, teriparatide and denosumab, and she actually did very well. So your thoughts on B1, B2, and B3 fractures in the current status of ORIF versus revision? Quick comment, Samantha.
Well, I mean, I wanted to come back on that because I know you've treated her with teriparatide, etc. But did you not consider using cortical strut grafts? Because I mean, these medications are not without potential complications.
Yes, of course, medical strut grafts is a definite consideration, but in a lady of 80 years old, having a fracture which is splitting more than 25% of the stem, the basic thought process was either you use allograft and risk a revision, and that too, you should have fresh frozen allograft to have any structural support there. Otherwise, taking autograft in an 80-year-old with an asthma, with the comorbidities, an ASA2 or /3, we chickened out of that one and chose to just do a distal fixing stem and give her medical support, and she did well.
Looks like a good outcome, yes.
So would you routinely do strut grafts if I were to ask you? Because our practice is not to use strut grafts routinely. We do have a fresh frozen allograft bank after I visited Nikhil, and it's been functional for the last 7-8 years.
So in my practice, I tend to use a strut graft. I mean, it's important that it's adequately prepared and it's soaked, well in advance, because otherwise the strut graft can fracture, and therefore the whole point of it being there for giving structural integrity is lost. So you've got to be careful how you use it and make sure you don't tighten the wires around it too much. But I tend to use that more than giving patients teriparatide, etc. But obviously, that's something to consider, and for select cases, it's something I would use.
Great, thanks. So just to summarize where we are going with the case, so periprosthetic fractures essentially can be a cause or effect. So falls or pains can be a cause or effect phenomenon. The Vancouver system gives us a lot of definition about the injury, and it's been expanded. The Duncan and Mastery's classification has been expanded, and that UCS classification gives very good additional information as well. What is important is an algorithmic approach based on clinical symptoms, radiography, the type of stems that we have used, and finally the intraoperative assessment of stability in Vancouver B situations. The principles for exchange are anatomical reductions, accurate mechanical realignments, and distal fixations. And one has to be very wary when we decide between a B1 and a B2, because the revisions tend to have done better in terms of a 1-year mortality as compared to ORIFs. And 47% of fractures diagnosed and treated as B1 actually turned out to be B2s at subsequent revision. So we have to be careful with what we label as B1 or B2. And unless proved otherwise, depending on what you've used, one has to take a call on whether to fix or revise. And obviously, the long-term results of revision for PPF are poorer than those for aseptic loosening. So your final thoughts on the case and the take-home for the audience, Samantha, before we close.
Yes, I mean, I would say that I would caution in patients 80 years and above to consider using a cemented stem because of the significant risk. It's 14 times more likely to get a fracture with an uncemented stem compared to cemented. So I would say that I would consider that. But if you are going to use the uncemented stem, you've got to be very careful and have a high index of suspicion, looking for fractures. If there is a fracture that occurs intraoperatively, then you really need to follow it all the way down and make sure that it's appropriately treated. You want to get anatomical reduction of the bone. You want to get a good fill of the canal with the prosthesis. And then you've got to pay attention to whether you want to weight bear the patient early or not. And then consider adjunctive measures such as strut grafts, use of teriparatide or any other type of medication to try and strengthen the bone. But the important thing is when dealing with the fractures, deciding on whether the fracture is stable or not, and the algorithm that we've shown you is very useful. And if the fracture is loose, then it's best to actually revise the stem rather than just do fixation, if the patient is working well enough.
Great, thank you. Great point, Samantha. And I think we will close the case here and see if there are any questions in the.
So thank you, Abhay. I think so. A very excellent case. I think some of take-home point B1, B2 fracture, periprosthetic fracture, we need to determine intra-op, not just based on the X-ray. So I think the choice of cemented or cemented stem in elderly patients is sometimes controversial. Age, just a number, but I think the bone quality is one of the key. So one quick question to you. Do you think there's any difference in periprosthetic fracture rate between different kinds of cemented stem? I can see you use a collarless Corel in your case. Do you think collar cemented stem would lower your incidence of periprosthetic fracture?
Yeah, so basically, the composite beams, if they have a metaphyseal fracture or anything around the stem, the body of the stem of the prosthesis, those are obviously going to be loose because, and they need to be revised. In contrast to the polished tapered stems where the stability is at the cement bone interface, and you're actually also looking at the stem subsiding a bit to gain stability. So those are stems which could be stable. So between the cemented stems, obviously the composite beams, the dull matte finishes are the ones, if they have a metaphyseal fracture, they are definitely loose and have to be revised.
Do you think there's any difference in the periprosthetic fracture rate between different cemented stem?
The difference, the collared or the collarless, would you like to take that, Samantha? A difference in periprosthetic fracture rates between collared and collarless stems.
Or the stems.
Can I come in?
Yeah, sure.
So we have Josh Lamb working with us, and he's done a lot of good work with Professor Pandit from Leeds, and he's given some very good keynote addresses in recent British Hip Society meetings. Basically, he's done his PhD on looking at different types of stems and the risks of periprosthetic fractures. And particularly because over the last 20 years, what has happened demographically is that the bulk of revision surgery in the elderly people is now periprosthetic fractures. And to cut a long story short, the message is that if you have to use an uncemented stem, then a collared corral is much better. And in cemented stems, the risk of periprosthetic fractures, particularly in elderly people, is higher with tapered polished stems compared to the old-fashioned composite beam Charnley stems.
So thank you for the highlight. I think we load the update. I think the bone quality is one of the key. Periprosthetic fracture in elderly patients, no matter intra-op fracture or the early post-op fracture, still one of the problems when we did a total hip in elderly patients. So thank you. So let's see if we have any other questions.
I think
a couple of questions on the chat box.
I think we've got 1 minute to wrap up those questions if you have time.
Okay, uncemented hip at 80, wasn't cemented hip a better option? So we've answered that. You could use an uncemented hip, but it's best to do a hybrid, which is better. But we chose because of the patient's bad asthmatic condition. So there is subsidence on the right hip. Well, too early to say subsidence because there was no displacement. It's only when we did a stress examination in the OR under Shyam that we realized the right hip was broken. So we did revise it. Is it safe to do cemented stems in elderly more than 70 years, as this would minimize the risk of such fractures with non-cemented stems? Yes, cemented stems is a way to go with the elderly people. And how does the interaction with the patient and relatives go, and how to approach talking to the relatives and encountering with such complications? So yes, when you consent them for a particular procedure, you let them know the risks. And when there has been a problem, then you actually go back and tell them that this is what has happened and this is what needs to be done. And more often than not, they do find logic into what you've done before and after surgery, and they should be all right. So why did we use uncemented femur without collar in elderly patients? So Corel cemented stem is not something that is freely available in India at this point in time, and it's something that's being introduced into the country, especially with the NPPA guidelines on cost. That is a bit of a availability issue. Isn't it better to go for cemented collar stem? Is a safer option in osteoporotic patients? Samantha, would you like to take that? Cemented collar? Did you do a cemented collar?
I mean, I don't have any experience with it, to be honest. Sorry, what was the question? I'm just trying to see it here.
Is it better to do a cemented collared stem as a safer option in osteopenic patients?
I think
anyone does a cemented
he already summarized the key things about the periprosthetic fracture. Cemented stem, I think lower incidence of periprosthetic fracture compared with cementless. Cementless, among various design, probably the collar one would have a lower incidence. I think thank you, Nikki, for the highlight. So I think we answer most of the questions. So we need to come to the end. So I need to thank British Hip Society for organizing such excellent webinar. So we have good discussions about instability, infections, and periprosthetic fractures. So I think with the legacy of a total hip replacement in UK, I think no matter our participants, our case presenter from our society, definitely learn a lot from the wisdom you share. So thanks a lot. So I'm sure our collaborations won't stop here. I'm sure we will have a much more future collaborations. So thank you, Satish. Thank you, our presidents. So, and then thank you all the BHS faculty here.
Thank you. Thank you, Lewis.
Thank you.
Thanks, guys.
Thank you, Lewis. Superb set of talks, and well done, Satish, for organising that.
Thank you very much.
Yeah, thank you. Thank you.
Thanks, Lewis. Thanks, Samantha.
Our collaboration will continue. Thank you.
Thank you very much, guys. Bye-bye.
Bye-bye.
Excellent.
Thank you. Bye-bye. Thank you.